Welcome to Roadmap to Residency. Today we're tackling one of the highest yield cardiology topics for your Step 2 clinical knowledge exam, valvular heart disease. This video will focus on test-taking strategies and question STEM patterns rather than reteaching all the content. I strongly recommend reviewing your first aid and UWorld materials before watching this video so you can follow along. We're going to walk through real question patterns, teach you how to recognize the classic stems, and show you exactly why the right answer is right and why the wrong answers are wrong. If you find this helpful, please like, subscribe, and check out our expert tutors and residency advisors at roadmaptoresidency.com. Let's dive in. By the end of this video, you'll know how to spot valvular disease question stems from a mile away. We'll focus on the four major lesions: aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. For each one, I'll teach you the physical exam buzzwords the test writers love to use, and more importantly, how to use those clues to pick the right answer. Remember to reference your first aid cardiology chapter and UWorld question bank for the foundational pathophysiology. This video is about applying what you already know. Here's your first test-taking framework. When you see a question about murmurs, immediately ask yourself two questions. First, is it systolic or diastolic? Second, where is it loudest? These two pieces of information alone will narrow down your differential dramatically. Here's the pattern to memorize. Systolic murmurs include aortic stenosis and mitral regurgitation. Diastolic murmurs include aortic regurgitation and mitral stenosis. And for location, remember that aortic valve problems are loudest at the right upper sternal border, while mitral valve problems are loudest at the apex. When you see these buzzwords in a question stem, your diagnosis should click immediately. Let me give you the buzzwords that test writers love. For aortic stenosis, look for a crescendo-decrescendo systolic murmur that radiates to the carotids, and symptoms like syncope, angina, or dyspnea. The classic triad is syncope, angina, and heart failure. For aortic regurgitation, the murmur is diastolic and decrescendo. The physical exam findings are dramatic: wide pulse pressure, bounding pulses, and sometimes visible head bobbing. For mitral stenosis, you'll see a low-pitched diastolic rumble with an opening snap, often in a patient with history of rheumatic fever. And don't forget the atrial fibrillation association. When you see these patterns, the diagnosis should be automatic. Make sure to review your first aid murmur table for a complete list of physical exam findings. Let's work through our first case together. Before I reveal the answer choices, I want you to process this stem. What are the key findings? We have an elderly man with syncope on exertion, chest pain, and dyspnea. That's the classic symptom triad of aortic stenosis. The physical exam confirms it. Crescendo-decrescendo systolic murmur at the right upper sternal border, radiating to the carotids, with a delayed carotid upstroke, which we call Pulsus, Parvus et Tardus. This is textbook aortic stenosis. Now, what are they going to ask? They want to know the next step. Keep this case in mind as we go through the answer walkthrough. Here's how to approach this question systematically. First, analyze the clues. The syncope, exertional angina, and dyspnea form the classic triad. The murmur characteristics and delayed carotid upstroke clinch the diagnosis. Second, recognize the surgical implications. This is symptomatic severe aortic stenosis. Without surgery, these patients have very poor outcomes. But before surgery, we need to confirm the severity. Third, choose the correct answer. The answer is transthoracic echocardiogram. This will give us the valve area, the gradient, and help plan the intervention. Don't be fooled by cardiac catheterization as a distractor. That's only needed if we suspect coronary artery disease before surgery, not as the initial diagnostic step. The echocardiogram comes first. Now let's look at a different pattern. Here we have a middle-aged man with intravenous drug use history presenting with dyspnea. The blood pressure is the huge clue here, 160/50. That's a massively wide pulse pressure of 110. We also have a decrescendo diastolic murmur and bounding pulses. This is classic aortic regurgitation. The question is asking about physical exam findings, so they want to see if you know the associated signs. The intravenous drug use history is also a hint toward endocarditis as the etiology. Let's see how to approach this. The board exam loves testing the physical findings of aortic regurgitation because there are so many named signs. Let me give you the high-yield ones. De Musset sign is head bobbing with each heartbeat. Quincke pulses are visible nail-bed pulsations, which is exactly what this question mentions. Corrigan pulse, also called water hammer pulse, describes the rapidly rising and collapsing peripheral pulse. Trobe sign is hearing pistol shot sounds over the femoral arteries. And the Austin Flint murmur is a mid-diastolic rumble at the apex caused by the regurgitant jet hitting the anterior mitral leaflet. The correct answer in this case would be whichever of these findings is listed among the options. Review your first aid for the complete list. Surgical indications are extremely high yield. Let me give you the framework. For aortic stenosis, surgery is indicated when the patient becomes symptomatic with severe disease. The symptoms are syncope, angina, and heart failure. Also, if the ejection fraction drops below 50%, surgery is indicated even without symptoms. For aortic regurgitation, surgery is indicated for symptomatic severe disease. But here's the key difference. We also operate on asymptomatic patients if there's evidence of left ventricular dysfunction. The cutoffs are ejection fraction below 55% or left ventricular end-systolic dimension exceeding 50 millimeters. These numbers are fair game for board questions, so know them cold. Review your question bank for practice problems on these specific cutoffs. This is a classic board question setup. Let's break down the clues. We have a young woman from a region where rheumatic fever is endemic. She has a history of untreated pharyngitis as a child, which is code for streptococcal pharyngitis leading to rheumatic fever. The irregularly irregular pulse tells us she has atrial fibrillation. The murmur is a low-pitched diastolic rumble at the apex, with an opening snap and a loud first heart sound. All of these findings point to one diagnosis. The chest X-ray finding of left heart border straightening indicates left atrial enlargement. This is mitral stenosis from rheumatic heart disease. Let's walk through the key teaching points. The history of rheumatic fever is the most common etiology worldwide, especially in developing regions. The physical exam findings are classic. Opening snap followed by a diastolic rumble and a loud first heart sound. Here's a test-taking pearl. The shorter the interval between the second heart sound and the opening snap, the more severe the stenosis. This is because higher left atrial pressure opens the valve sooner. The complications are important for board questions. Atrial fibrillation develops from left atrial stretch. Hemoptysis can occur from pulmonary congestion. The stroke risk is high, so anticoagulation is essential. And Ortner syndrome, which is hoarseness from left atrial compression of the recurrent laryngeal nerve, is a favorite board factoid. This question tests mechanical complications of myocardial infarction. The timeline is key. This is 5 days post-infarction. The patient suddenly decompensates with a new holosystolic murmur at the apex radiating to the axilla. This is acute mitral regurgitation from papillary muscle rupture. The inferior wall infarction is important because it supplies the posteromedial papillary muscle, which has a single blood supply and is particularly vulnerable to rupture. This is a surgical emergency. Here's the key distinction the boards love to test. Acute mitral regurgitation is a surgical emergency because the left atrium has not had time to compensate. Blood backs up into the pulmonary circulation immediately, causing flash pulmonary edema. Contrast this with chronic mitral regurgitation, where gradual left atrial dilation accommodates the regurgitant volume, and patients may be asymptomatic for years. For acute mitral regurgitation post-infarction, the management is emergent surgery. Stabilization measures include afterload reduction and an intra-aortic balloon pump, but these are bridges to the operating room, not definitive treatment. Make sure you can differentiate papillary muscle rupture from ventricular septal rupture, another post-infarction complication with a new murmur. Let me give you a concrete test-taking strategy for murmur questions. Think of it as a decision tree. Step 1. Is it systolic or diastolic? This immediately cuts your differential in half. Systolic means aortic stenosis or mitral regurgitation. Diastolic means aortic regurgitation or mitral stenosis. Step 2. Where is it loudest? Right upper sternal border points to aortic pathology. Apex points to mitral pathology. Step 3. Look for the buzzwords. Radiation to carotids equals aortic stenosis. Wide pulse pressure equals aortic regurgitation. Opening snap equals mitral stenosis. Step 4. What's the clinical context? Age and risk factors help confirm your answer. If you follow this system, you'll get these questions right consistently. Let me leave you with your action items. For study resources, focus on the Valvular Heart Disease chapter in First Aid and work through all the UWorld cardiology questions, specifically flagging murmur questions for review. The American Heart Association guidelines have the most current surgical indications, and consider using audio resources to actually hear the murmurs, as this helps cement the patterns. Your key takeaways are: use the murmur framework every time, know your surgical cutoffs, recognize the buzzwords, and always differentiate acute from chronic presentations. Thank you so much for watching. If this video helped you, please hit that like button and subscribe to our channel. And if you want personalized tutoring or residency advising, visit roadmaptoresidency.com to connect with our expert team. Good luck on your boards.